It's 4 p.m. Italian time, so it's the great moment in which we start indeed with a great project, acronym for graduating residents enhancing active teaching. And we start as always with a great image of the Italian pavilion at the Universal Expo Dubai, made by 3 upside down boats as a metaphor of the journey we are all having around the world. Of course, we are starting now the counting down to be together in person next February at the Universal Expo in Dubai, connecting experts, properly informing patients. And of course, we look forward for enjoying the more than 190 countries involved in this huge project. And here we see some of the pavilions in honor of the nations in which we will provide simultaneous translation today, so Russian, Spanish, and English. So remember to choose the channel you prefer. Remember, you can make questions in whatever language in the question and answer box. They will be answered during the webinar, and if not live in the following days in written forms. We will provide international CME credits, so remember to reach out to the organizing secretary for obtaining the certificate. And we look forward indeed to start a brand new educational adventure on the Venus Road to the Winter Dubai. Because we have noticed, of course, that we can engage the colleagues. We look forward for doing a little bit more in terms of audience engagement. So we will enjoy later on the evidence-based comment from the audience, and even more the new adventure that is indeed dedicated to the residents. In terms of residents engagement, indeed, we thought about this nice paper we read, and so we came to the conclusion that we really have to put them in the first line because they are a priority. I really like this drawing that is stating, I suspect we'll find the coffin painter in the last coffin, and indeed they will be the ones bringing our discipline forward after us. So it's my pleasure to introduce 5 brilliant residents from different nations who have been selected thanks to their mentors from their own universities, and also thanks to the involvement of other mentors who will co-work in the presentations you will enjoy during this initiative that is focused on another topic that is usually under considered in our Venus world, which is peripheral arterial disease. This is an interesting paper that was recently published, pointing out how many cases we have of chronic venous disease in PAD patients that are not considered, and vice versa, and how managing both of them is of crucial importance. So I deeply thank you, the stellar faculty that is involved today in this group effort. I deeply thank you sponsors like MEDI who are allowing us to provide educational initiatives, moreover believing in the involvement of the new generations. And I deeply thank the travelsmates that I consider family, so Professor Bottini and Professor Che, to whom I will pass the mic now. Oscar?
Thank you, Sergio. Welcome everybody to this great project. Thank you all for participating in another opportunity to share science with the stellar experts from all over the world. Remember, Spanish speakers can make questions in Spanish, writing them in the question and answer box.
Thank you so much, Oscar. Now, Willie.
Good morning, good afternoon, good evening, everyone. Thank you for my friends. Please enjoy the great project that we have ongoing. And please make your questions in the Q&A box, even in Chinese if you needed to, and I will translate. Thank you.
Thank you so much, Oscar and Willie. As always, we start an educational journey with the good omen of a giant, in this case, Professor Bibili from George Washington University, and here is his opening remark.
Good afternoon, ladies and gentlemen. I would like to congratulate and thank to Professor Sergio Gianesini and the organizer to initiate such a unique educational program directly involving with the resident to interact with world-renowned experts to provide a bird's eye view on edema management to the phlebologists in particular to help them equally able to manage veins, lymphatics, and peripheral arterial disease associated edema as a whole. Thank you.
And with this, we deeply thank Professor Bibi, and we get started with the scientific part. As I said before, we will have 2 brilliant residents, starting from Dr. Leandro Nobrega from Porto University, who will present the talk, and then we will have 2 great mentors in the figure of Professor Luri and Professor Mansilla for the discussion. And since Dr. Nobrega is coming from Porto University and is a resident of a brilliant mentor like Professor Mansilla, I will ask Professor Mansilla to introduce him before we get started.
Thank you. Good afternoon. Thank you, Professor Sergio Gianesini, Professor Oscar Bottini, and Willie Chim, my good friends and my great friends, I would say. It is a great privilege being here today, and we can start with Leandro. Leandro is a second-year resident in my department of angiology and vascular surgery, and he will present the pathophysiology of peripheral arterial disease. And again, as Sergio mentioned, I would like to invite all the attendees to put their questions on English, Chinese, Spanish, and even in Portuguese. I can translate if you want. So please, Leandro, go ahead. Thank you.
Hello to all. As Professor Mansilla said, my name is Leandro Nóbrega, and I'm a vascular surgery resident in Porto. I would like to start by saying thank you for this opportunity and congratulate the organization for this initiative. And I would also like to declare that I have no conflicts of interest. The prevalence of atherosclerotic arterial diseases and its risk factors have been increasing in recent years. In the case of peripheral arterial disease, it has an exponential increase after 65 years of age and has a prevalence of about 20% in people with 80 years of age. In the last few decades alone, the number of patients with peripheral arterial disease has increased by 23%. And there are several risk factors that include smoking, hypertension, dyslipidemia, diabetes, inflammation, and chronic kidney disease. All of them can contribute to its pathophysiology. And there are three main theories that try to explain its pathophysiology. One of them is the lipid hypothesis, where the process starts with subendothelial lipid retention. The other one is response to injury hypothesis, where endothelial lesion starts the process. And the other one is the monoclonal hypothesis, where a clonal expansion of smooth muscle cells is responsible for starting the process. None of these theories fully explains the pathophysiology of peripheral arterial disease. However, there are several components that we need to consider. One of them is LDL retention, that although it doesn't usually happen in the healthy endothelium, it usually is an early event. When these LDL particles are retained, they can be oxidized, they become chemokines to monocytes, and they also can be absorbed by macrophages to form foam cells. These monocytes also seem to play an early role in atherosclerosis, and they usually interact with the healthy endothelium. But in the presence of chemokines like oxidized LDL, they can adhere to the endothelium and migrate to the endothelial space and start the inflammatory process. These monocytes, once there, can undergo some modulations and become resident tissue macrophages. These macrophages, once activated, will increase the expression of the scavenger report, which is a receptor that is responsible for absorbing the oxidized LDL, will stimulate their own replication, and also will increase the pro-inflammatory cytokines production. These macrophages seem to also play a role in thrombosis, as they produce matrix metalloproteinases and procoagulant tissue factor. On the other hand, the cells of the adaptive immunity may also play a role in atherosclerosis, as they can modulate the immune response. Natural killer T cells accelerate atherosclerosis, while regulatory T cells suppress the inflammatory response. In advanced lesions, the atheroma T cells display markers of chronic activation and seems to produce pro-inflammatory cytokines. One other type of cells that are involved are the smooth muscle cells. As in a pro-inflammatory environment, they can migrate to the intima and can be activated. Once activated there, they will stimulate their own proliferation as well as other types of cells. They also can stimulate and produce collagen that can be part of the fibrous cap in a mature plaque. This calcification process can start when the smooth muscle cells acquire an osteochondrogenic type, for example, when in the presence of turbulent flow, high pressure, or inflammation. Ultimately, this process will lead to osteoblast induction that can lead to calcification of atherosclerosis plaque. And for all this process to happen, there are several pathways that are activated. One of the most studied is the NLRP3 inflammasome, although recent evidence suggests that the main one involved may be NLRP1. Nonetheless, the presence of LDL will activate inflammasome that will in turn activate caspase-1. Caspase-1 will be responsible for activating interleucin-1 beta and interleucin-18, that are two protein pro-inflammatory cytokines. As atherosclerosis is a pro-inflammatory pathology, there are several biomarkers that have been studied. The most studied one and the most clinically used is the high sensitivity C-reactive protein, and its values have a prognostic value regarding cardiovascular risk, and its predictive value is similar across different populations and is as robust as other biomarkers. The atherosclerotic plaques that are formed, the current evidence suggests that they have a dynamic evolution that can go from a slow and steady growth to a growth spur when, for example, there is a thrombotic complication. This in situ thrombus does not always lead to total occlusion, as they can induce a healing process that will reduce the lumen of the vessel. And these thrombotic complications may happen through 4 possible mechanisms. Plaque fracture that will expose the tissue factor, interplaque hemorrhage, apoptosis of the endothelium, or erosion of a calcified nodule through the intima. Lastly, it's important to consider the overlap with venous pathology, as they may share some risk factors. They are both triggered by factors that activate the coagulation system and the inflammatory pathways. In both pathology, the endothelial dysfunction may play a role, including dysfunction of the endothelial glycocalyx. On the other hand, VTE patients of unknown origin, as well as provoked VTE patients, especially those with cancer-associated VTE, have increased risk for cardiovascular events. Thank you for your attention.
And we congratulate Leandro for the brilliant talk. Please stop sharing, Leandro, so we can move forward with the comment of the first mentor, that indeed is Professor Fidor Luri. Fidor, would you like to go live, or if not, we have your presentation ready?
If you can go recording, that will be safer.
Okay, here we
Thanks.
go.
Thank you, Dr. Nobrega, for a very good description of the pathology behind the peripheral arterial disease. I would like to address some similarities and differences between arterial and venous disease based on your presentations, and specifically focus on 2 aspects of aging that you mentioned as the risk factor for peripheral arterial disease and no conflict of interest. The aging process in the arterial system is well known. Here is the paper that presents the aging process for aortic valve, which is connected to both flow dynamic changes and thrombosis. But the similar changes happen in the venous system, although deep veins are more prone to develop atrophic and sclerotic process in the venous valves, whereas superficial system solely has atrophy of the venous valve cascade. See it here. Here's a paper that tried to numerically simulate what happened with the blood flow when the process happened in venous valves, specifically looking at the 4 phases of the valve cycle. And if you can see, unlike the normal cycle, which is very symmetrical flow, the changes in the venous valve associated with aging can cause very substantial changes in the dynamic of the floor, and also changes the shear stress that is applied to the surfaces of the venous wall and the venous valve, similar to what we see in arterial plaque development. More of this, the other studies show that platelet distribution change is also prone to development of a thrombosis, which leads to a well-established mechanism of high shear rate thrombosis that mostly happen in the arteries with the unfolding of familial growing factor and capturing platelets and even not activated platelets and then forming the blood. For the carotid disease specifically, we look at the numbers, and the critical number of shear rate is about 8,000 per second. So you can see in the venous reflux, it's not directed straight to the line, but rather most time is affecting the venous wall. And then you calculate the shear rate, it actually exceeds the arterial shear rate, making it possible that the same mechanism may play a role in a venous thrombosis. So with the venous versus arterial system, when it comes to the pathology, peripheral arterial disease can lead us to some mechanism affected veins. And so it might be more pathological features that are in common, although we have to emphasize that those systems are very, very different. Thank you for your attention.
And we thank Professor Luri because he's always our good omen at the beginning of every activities of ours. And now we go all the way to Portugal with Professor Armando Mansilla for a second comment from the mentor.
Thank you, Sergio. And thank you again for this great initiative. It's a pleasure being here today. And it is even a great pleasure being together with my good friend Fedor Luri as my co-mentor in this Leandro Nobrega presentation. I think that Leandro addressed a lot of important issues related with pathophysiology of peripheral arterial disease. More than making a comment, I would like to invite the panelists and the audience to make a few comments and giving their thoughts on things like, for example, I wonder to know how do you consider mapping the genes in the future as being part of this equation to clearly understand the whole picture on the pathophysiology of peripheral arterial disease. Another point that is related with the location of the plaques. Leandro already mentioned, and you know the importance of the shear stress, measure curvatures, angulations, and so on. But I wonder to know if you believe that we can give the importance of hemodynamic factors to justify the different patterns of PAD, because if we know that that is true in the majority of patients, it is much more difficult to understand how in different patients, how, for example, to justify on diabetes to spare a few arteries in comparing with the others. For example, the foot arteries are sparing. What can justify this? How can we justify the pattern of PAD, the central pattern of PAD in women, or the abdominal coral leaf? Can you attribute all these reasons only to hemodynamic factors? And another important point, not only related with pathophysiology, but related with PAD, it is that in this panel we have vascular surgeons, but also angiologists and internal medicine. So it is crucial in our hospitals, in our departments, to have multidisciplinary vascular teams to treat these patients. And it is really important, and initiatives like this one and with similar ones, the importance of improve and develop the public awareness of the importance of PAD, because I believe that comparing with other arterial manifestations of atherosclerosis, the PAD, it is underestimated and undertreated comparing with coronary artery disease or with cerebrovascular artery disease. And it is crucial for all of us to improve this public awareness. Last but not least, and Fedor already mentioned this much better than I will, and that I can do that, it is the potential similarities with venous disease. If we have evidence of if we don't have enough evidence, if it is only in vitro or if in vivo, the clinical trials are robust enough to have important message from this, namely if we have pharmacological treatments that can act in this at baseline in this inflammatory process, and if can or not block the release of these inflammatory mediators in this cascade of the peripheral arterial disease. Sergio, my comments. Thank you again for your invitation, and I'm very pleased if the panelists and the audience can participate now with a lot of questions, special for Leandro.
Deeply thank you. Thank you. And also for showing us that the more we know, the more we understand how much we don't know. And let's see if we can know the answer to the comments now of experts from all around the world, starting from Egypt with Professor Ayman Fakhri, president of the Egyptian Venous Forum. So Ayman, please pull over. We don't want any car accident, and just make it.
Thanks, Sergio. Fortunately, I'm not driving. I sit beside the driver, and he's a very good one. Thanks, Sergio, for the invitation. I really enjoyed your company as usual. And thank you, Leonardo, for the presentation. It was very good. I have a question for Leonardo and maybe for Professor Mancella, discussing how can smoking as a risk factor affect the pathophysiology of peripheral arterial disease?
Thank you so much, Ivan. We will start with Leandro, if Leandro has a comment, and then we'll go to Professor Mancilla.
Yes, thank you for that question. In fact, smoking is a known risk factor for peripheral arterial disease, and it can affect. I think it can affect the pathophysiology in several ways. One of them is, for example, that smoking induces a pro-inflammatory systemic state, and this can also lead to nitrous oxide production, interfere with nitrous oxide, and this diminished nitrous oxide, for example, can facilitate the entry of LDL in the vascular wall. On the other hand, smoking is also known for being a risk factor for new events, even after revascularization. So there may be some other effects that we still don't know that can contribute to the pathophysiology of peripheral arterial disease.
Thank you so much, Leandro. Armando?
Thank you, Sergio. Leandro already mentioned, in my view, the important points related with the importance of smoking in this pathophysiology and the importance of the nitric oxide and the inflammatory consequence. I would say that it is crucial to understand that, and it is crucial also to understand that besides the importance of having smoking as one of our most important risk factors in this pathophysiology, is still a great risk factor for all our patients after being revascularized. It doesn't matter if it is by open or endo, and we have to share this importance with our patients in order to improve the patency of all our technical procedures, understanding the importance of smoking as a major risk factor for occlusion in the future.
Thank you so much, Leandro and Armando. And now we fly all the way to US. It will be Professor Bottini introducing the next top expert.
Thank you. Let me introduce Professor William Marston, world-renowned expert from North Carolina University. Professor Marston.
Professor Marston is engaged in the operating room, so we will play the video.
Hello, my name is Bill Marston from the University of North Carolina. I'd like to thank Sergio and the organizers for inviting me to participate in this great session. And I would like to compliment Dr. Nobrega for an outstanding and concise summary of the pathophysiology of PAD. I really have more of a comment than a question, and he mentioned calcification of vessels along with traditional atherosclerosis as an etiology of poor flow. And in patients that have the most severe form of PAD critical limb ischemia, we find that this component, the calcification, diffusely affects distal vessels in the lower leg and foot. Particularly, this involves patients with severe diabetes and renal failure, and they have the highest risk of limb loss. Many of these patients are difficult candidates for revascularization, so I think these will really need a pharmacologic solution to enable us to improve limb preservation in many of these difficult patients. So I would challenge those, particularly young members attending this session, to look for these type of pharmacologic solutions to distal and diffuse arterial calcification. There are some agents currently under development in clinical trials that hopefully will be available in the not too distant future. Again, congratulations on an excellent summary, Dr. Nobrega, and I appreciate the participation opportunity. Thank you again.
And with this, we deeply thank Professor Marston. Leandro, do you have any comment on this?
Yes, I want to thank Professor Marston for his his comments. And regarding the classification, yes, that is especially true in diabetes patients. As we all know, they are at increased risk of medial calcinosis. That is a known phenomenon in diabetic patients, but it is also in some patients, even in heavily calcified leg arteries. Sometimes they have a spared pedal artery. And on the other hand, right now we don't know if there is only hemodynamic factors in game, because, for example, in diabetic patients, we have also the neuropathy that can also play a role in the distribution of calcification of the arteries.
Thank you, Leandro. And now we fly all the way to Japan. It will be Professor Chi introducing the next top expert.
Well, next we have a great friend of the VWIN Foundation, Professor Mo from Yokohama University. Mo?
Here we are.
Thank you very much for appointing me as a discussant for the great project. I'd like to thank you, Dr. Nobrega, about a complete review of the arterial disease and also relationship to the venous disease. This is very fruitful presentation, and thank you very much. Here is my comment and question. Thank you very much for mentioning about a very important paper recently published, Incidence of Major Adverse Cardio Arterial Event among the patient with provoked and unprovoked venous thromboembolism. This is from the study for the retail registry. This study demonstrates provoked VT compared with unprovoked VT was significantly associated with the increased hazard ratios MACE. Hazard ratio is 1.4. Cancer remained a significant adjusted predictor for both MACE and male in those with a provoked VTE. These findings are important for venous patients management in the future. Thank you very much for this citation for the important paper.
And we have a technical issue. Wait a second. Let me start again.
Physiology is a common artery in between the artery and venous disease, but treatment is somewhat different. Compression for the vein, but not for arterial disease. This is a paper about treatment of the arterial and venous leg ulcer. Dr. Motzi demonstrates in a mixed association, in elastic compression up to 40 mHg does not impede arterial perfusion and normalize the venous pumping function. Bandage is therefore recommended in combination with walking exercise for mixed ulcer. This is another important paper. Thank you very much.
And we thank Professor Mo, and I would take this chance of asking to the mentor, Professor Luri, if you have any comment on what we have just listened to, Fidor.
Well, thank you, Sergio, once again, and thanks for. I think it's an excellent discussion. If I may just address one question that came up, which was, I think, a very interesting question, because we're talking about arterial disease connection or commonalities with venous disease, and the question was what happened with the AV fistulas in the veins, and I didn't really have time to address that in my comment, but for the residents and future researchers, I encourage you to look at the Alandardix group papers, which identify genetic identity of the venous wall and arterial wall, and also what happened in when we create AV fistulas for dialysis access, the loss of this venous identity and transformation to basically arterial identity. And this is really interesting process crossing two diseases, especially because most of these fistulas we create in patients with diabetes, and some of them have peripheral arterial disease. So that those mechanisms are very interesting and probably we'll have to look into when we talk about potential pharmacological solutions for the disease. So thank you. It's an excellent question.
Thank you so much, Professor Luri, for this extra insight. And now we will fly all the way to Poland with Professor Urbanek, who we congratulate for a brilliant 30th anniversary meeting today of the Phlebology Society from Poland. And here is the comment.
Dear Leandro, dear Sergio, dear friends, we know that there are several risk factors which are common for arterial and venous diseases. We know that activation of the endothelial cells plays role, also the activation of the coagulation system in both these groups of diseases. We also know that the patients with DVT suffer more often for cardiovascular events, and we know that the patients with DVT, if treated by statin, can have the lower rate of post-thrombotic syndrome. So several connections between the systems, between the pathologies. We probably don't know all, but we should look forward to find these links, because it seems that we cannot think just about the separate arterial or venous pathology. Thank you very much for these presentations and for the great number of the new messages. Thank you very much.
Leandro, do you have any comment on this?
Yes. I would like to start by thanking Professor Urbanek for his comments. Indeed, there are some recent small studies that indicate that there may be some overlap with the pathophysiology, for example, if endothelial dysfunction or glycocalyx dysfunction, but there are still small studies that does not necessarily translate it to guidelines recommendations, but it's a start. It shows potential for pharmacological treatment, but we need more robust and randomized clinical trials in order to have the strong recommendations in our guidelines to better treat our patients.
Perfect. And now it's time to move to the audience. I see in the question and answer box a question in Russian, so I asked the simultaneous translation service to tell us the question. I cannot see the English version. So thanks God we have also Fedor with us. Can you see Fedor?
Yeah, Sergio, yes, I already partially addressed this question. That was a question regarding the AV fistula, why those flow disturbances that we observe in the veins, which may lead to thrombosis, do not happen in AV fistula. So I gave the partial answer to this because AV fistulas are genetically different. The genetic identity of the vein in AV fistula transformed to a different source. And I also will encourage you to take a look at our recent publication. Maxim Shaydukov was our research fellow, just published 2 months ago in Journal of Vascular Surgery, Venous and Lymphatic Disorders. The first study of the genetic identity of the venous valves in the deep system, the human, so it's a real human sample studies, and showing that it is very unique expression of genes in the area of venous valves, and that's why it's likely that the flow disturbances, particularly in this area specifically, may lead to initiation of venous thrombosis.
Thank you so much for helping my rusty Russian, Fedor. And I will ask you for extra help and to all the panel as well on eventual comments we can have on these talks. One of mine would be, for example, we talked about the smoke risk associated with arterial and also venous. Could you dive a little bit more on the pathophysiology behind that in the differences in the venous versus arterial? I don't know if there is some of the experts of this panel who like to talk more if we have any evidence in terms of pathophysiology effect of smoking on venous rather than arterial endothelium.
I think that Leandro can develop a little bit more this topic. Leandro, are you able to do that?
Yes, regarding the arterial pathophysiology, as I said before, it probably involves interference with nitric oxide production and also a pro-inflammatory state that can promote atherosclerosis. Regarding the venous disease, probably the pro-inflammatory state, and also the nitric oxide may have influence in the function of endothelial cells in the venous vessels, and this function may lead, for example, increased risk for a DVT, or it may interfere with the function of the valves, and may lead to increased risk of a dysfunctional valve and chronic venous disease.
Thank you. Any other comment, Armando, on this?
No, Sergio. I would like to have one more comment with what Fedor just mentioned concerning the AV fistulas. If it is or not, Fedor, in your opinion, if it is or not important to consider that the majority of AV fistulas are in the upper arms, comparing with the clinical expression of the PAD on lower limbs, what is not the same thing? Well, just a provocative question between friends.
Right. Well, I think it's an excellent and not so much provocative question. Absolutely right. I mean, it's true. The majority are in the upper arm, and it's different biologically and different hemodynamically from the arteries on the legs, where we have both, by the way, arterial and venous disease. That's excellent question.
If I can go back to the similarities with venous and the clinical activities we can do with these patients, ABI is considered usually a threshold as a parameter, but we have also a publication in 2019 showing that for compression, for example, use, the range of 0.6, 0.8 has huge variability in the indications according to the different documents. Would some panelists like to comment on the use of compression in this range of ABI and how much ABI alone can guide us or not? Is there somebody?
Well, if I can start, Sergio, that's a fantastic question, because a few years back when we developing the guidelines for venous ulcers, this question came up, and at that time the criteria was 0.8. So with the ABI less than 0.8, the compression should not be used. Before that, and there are quite a few studies that show that you can safely use it in 0.6 and above. So that's how we change that. This is really complicated question. When we look at ABIs for peripheral arterial disease, we are looking for a maximum perfusion. So we are taking the highest ABI and the lowest ABI, and we look at how much of a perfusion can be done. So it's a different question. Now, the cardiologist look at the highest ABI as a predictor of cardiovascular disease and show this it's much better predictor. So it's more a perfusion pressure and the match of this perfusion pressure with the volume of the tissue rather than just index. And so, as you well known, that paper for Giovanni Mosti and Hugo Parch that emphasize this particular point, that perfusion pressure is probably more appropriate criteria compared to ABI. But I also will say that it also matter how much tissue is there. So you have a really big swollen foot. It's different from the tiny foot with the riddled skin.
Thank you so much, Fedor.
If I can add something on this, yes. Sergio. Of course, I completely agree with Fedor, but we noticed that sometimes it is difficult in our daily practice to measure that. So the point it is how to decide on routine basis, and in some patients, I think that it is also crucial to consider the grade of compression and perhaps the compression is the grade of compression that we have to decide for this particular patient on venous. It is not so effective that it should be, but it is what it can be concerning is the pattern of peripheral arterial disease. And we have to take decisions, difficult decisions on our daily practice. And the grade of compression, it is important because sometimes it is difficult to measure the perfusion. It's much more easier to do the API. I don't know if you agree on this, Fidor.
I absolutely agree with that, and you know, Willie, you should jump on that because you did some studies on the measuring of the interface pressure. We actually routinely do that now, measuring interface pressure of compression, because you're exactly right. And some patients, especially as patients with the critical limb ischemia and swelling, you actually can have very low pressure compression that is safe and help to heal ulcers. But then you have to know how much compression you apply, because otherwise you can get in trouble. Absolutely agree with you. Thank you.
Yeah, thank you, Fidor. I'm just going to add one comment since you named me. So one thing I want to just make sure that everybody understand, I think that there are different physiologic effects from the different type of compression, whether it be graduated compression, compression wrap, elastic, inelastic, and also compression pump. Because we all know for critical limb ischemia, compression pump at a very high pressure threshold, but with a very low period, meaning that it's a pulse type of compression that actually helps with the endothelial function in terms of nitric oxide release based on animal studies. So for compression pump, it actually has been validated in patients with critical ischemia who are refractory to any type of surgical endovascular revascularization means. So just my comment.
And indeed, it is a very interesting topic. We had some experience in our university as well, in which we were working on ABI, even like of 0.5, showing actually the greatest benefit in lower ABI patients, but of course you have to properly prescribe. So we were measuring near infrared retroscopy data in there. But of course, proper prescription must be made because, of course, you can create serious complication. And also a comment on interface pressure is that there is a paper that actually was shown to me by Fidor once about the interface pressure that is maybe the same along the leg, but based on the shape, you have variations up to 50% in the subcutaneous compartment. So it's even more complicated than this. I know that Oscar has a comment, maybe? Oscar?
Sí, en lo que, voy a comentarlo en español para que...
But stay in Spanish channel.
El primer comentario respecto a esto, estamos hablando de la compresión, no tengo la experiencia de los trabajos científicos como mostró Fidor o como mostró Mancilla recién, pero la realidad es que nosotros en la práctica diaria podemos ver que aún con índice tobillo-brazo de 0,5, 0,6, podemos manejar bien las compresiones incluso altas. Como dijo Willy, coincido totalmente, lo importante es la compresión que se ejerce en ese primer centímetro de superficialidad de la piel hacia abajo, porque realmente con compresiones inelásticas tenemos muy buenos resultados en la práctica diaria. En lo que se refiere a el diámetro, perdón, el espesor de la pared del vaso arterial, ya son conocidos los estudios de predicción en función de los peligros vasculares que pueden existir en los pacientes que tienen un grosor más elevado. Entonces sería interesante que los estudios que se realicen se comiencen a realizar a partir de cuando comienza a engrosarse la pared del vaso en los estadios iniciales. Y ahí podemos tener más información que la que hoy tenemos si empezamos los estudios tempranamente en estos pacientes.
Thank you, Oscar. And we will take one last question from the audience on revision of the femoral artery. Usually the largest plaque deposits are on the posterior wall. Can this be related to flow changes or metabolic syndrome? Leandro or some of the mentors, would you like to comment on this?
Probably it can be a little bit of both, because near the femoral common femoral artery there is a bifurcation, or the superficial and the profunda artery, and maybe the metabolic syndrome may predispose for plaque formation in that area. But I think probably we need more studies regarding that specific location to better understand why it is in the posterior wall and not in all the vessel.
I see the mentors ready to take the mic. Thank you, Leandro.
Yeah, just a quick comment, and it's mostly for the residents and future researchers to take a look at one factor that we kind of neglect for the last few decades is innervation of the arterial wall. There are studies that probably date 30, 40 years ago that show that difference in innervation is correlate very highly with location of atherosclerotic plaque. Now, I'm not aware of any mechanisms behind that, but it's an interesting aspect that is not in the current literature at all. So if somebody is interested to study that, that will be great.
Armando?
Thank you. Well, this is a difficult question and a little bit unfair to Leandro, even for all of us. I would say that in this particular location, of course, it is a bifurcation. Of course, we have the shear stress, but I would consider another point, that it is the kind of movement at this area. You just have movement in one sense and not in the other sense. Although perhaps it facilitates the deposition of the plaques in the posterior wall and not in the anterior wall, just because of the movement in this particular area. What does not happen, for example, in carotid artery? So sometimes we say that a carotid bifurcation is similar to a femoral bifurcation, but it is not related with movement. The movement on carotid bifurcation, it is always the same, because we don't have movements that are in different senses. What does not happen at femoral area.
Thank you so much.
Just a thought.
It's now time to close this first part, but not before making a comment on both arterial and venous disease that are both genetics and also environmental. And in this sense, resident performed really well, very probably because of genetic factors. So he was really well prepared, but also environmental factors like two great mentors. So thank you so much to the three involved in this session. And now we move forward and we fly all the way to London. That is in our Venus Ward, indeed the academic centers for excellence, with Professor Davis, of course, involved, together also with Professor Chi as mentors of a brilliant resident, Claire Webster, from Imperial College. So it will be Professor Davis introducing Claire to us and her talk.
It's a great pleasure to introduce Claire, who is not only a surgical trainee, but she is also a doctor in the Royal Air Force. So she brings quite a lot of different skills to this set. And I think you'll all enjoy listening to her presentation. And I'm sure Claire can give you some more of an introduction on herself. So I think we'll all look forward to this presentation. Thank you very much.
Thank you so much. Claire, you're welcome to share your slides and unmute yourself.
Good afternoon, colleagues, ladies and gentlemen. Thank you very much indeed for asking me to speak at this wonderful international initiative. And it's so great to see people from all over the world. Thank you very much for the introduction. My name is Spojanida Claire Webster. I'm a vascular trainee based at St Mary's Hospital in Paddington. As Professor Davies says, I'm also an officer in the Royal Air Force, and my role involves deploying overseas to areas required when I become a consultant in a year or two's time. So thank you very much for asking me to speak on the subject of chronic limb-threatening ischemia, and I'm very looking forward to talking to you about it and the following discussions. So chronic limb-threatening ischemia is a new term produced by the World Vascular Guidelines Group. in June 2019, replacing the old term, which was critical limb ischemia. To obtain the diagnosis, you require to have peripheral arterial disease plus rest pain, tissue loss, or ulceration for greater than 2 weeks. The new terminology aims to improve diagnosis, assist in management strategies, improve evidence-based care, and identify research gaps, and also provide more gravitas to the terminology, requiring how urgent it really is to intervene on these limbs in order to save them. So how do we initially evaluate the threatened limb? Of course, a good history taking is required for any medical history. And this is because critical arterial disease can present and masquerade as other things. We need to exclude things like osteoarthritis and spinal problems to really hone down whether peripheral arterial disease is suspected on the history. So an excellent history is paramount to start with. As I mentioned, peripheral arterial disease must be present, plus that clinical presentation of rest pain, ulceration, or tissue loss for that 2 weeks. The rest pain is actually felt across the metatarsal heads in the forefoot, as per the original description by John Cranley in 1969. The ulceration and tissue loss tends to present distally, starting off in the phalanx in the feet and going up towards the calf. Very painful, typically punched out ulceration on the distal extremity, and can often follow a trauma to the area that doesn't heal. The first question to us is the limb salvageable, or are we looking at a primary amputation situation, or are we going to make efforts to try and salvage that limb? We must evaluate the person with the limb, of course, and there's many heroic things we can do to salvage limbs, but it's very important to take a very structured approach to what is best for that individual patient. So who is the patient in front of you? What are their normal activities of daily living, their comorbidities, and also their choice, which is paramount. Scoring system can really help us, and they're recommended, and I'll go through those very shortly. And on our first meeting with these patients, we must have a realistic and pragmatic conversation with them and really manage their expectations. I find it very helpful to discuss limb loss early, so the patients know how serious this situation is, and that often helps their compliance with various interventions that we suggest, for example, stopping smoking and taking the medications that we recommend, because they know really what's at stake. So proper counselling and patient understanding of their disease is absolutely paramount. So how do we classify CLTI? So this is the same as the old terminology as critical limb ischemia. We stage it with regards to the Fontaine and the Rutherford classification, as we all know. So asymptomatic and mild claudication is not chronic limb threatening ischemia, but this is the presence of arterial disease with, first of all, no symptoms, or mild claudication, which is exercise induced. So that muscle isn't getting enough oxygen to supply its basic needs. Going on to moderate to severe claudication can be very debilitating, and onto rest pain, ulceration, or gangrene, which is the final stages in both classifications, where that muscle really isn't even getting enough oxygen to survive its basic functions, let alone with exercise. So the Y-FLY classification is a really nice way to quantify whether a limb truly is at risk, looking at aspects of the wound, the presence or absence of ischemia, and whether there's infection present. And this table on the left tells us whether we're looking at a high-risk limb or not. So once we've seen the patient and examined them and are suspecting arterial disease, we need to do a proper clinical examination to start with and feel their pulses. And this often gives us a lot of the information we need to know, and that where we're expecting to find the arterial disease. Bedside investigations, for example, handheld Doppler waveforms, ABPI, and arterial duplex can often be performed at the bedside. And cross-sectional imaging is subsequently employed to help us particularly image the aortoiliac segments, because there are various limitations to arterial duplex often in terms of artifact. We need to obviously be mindful of patients' renal function and also any metal implants and pacemakers with regards to MRI. Diagnostic angiography is very helpful. However, there are restrictions with regards to that, and there are morbidities associated with that in pseudoaneurysm. However, you can obviously intervene at the time of doing a diagnostic angiography, which is always helpful too. So the World Vascular Guidelines Group use this acronym PLAN, which is a really nice way to focus our thoughts in that evaluate the patient risk to start with, how severe is the limb, and the anatomic complexity, which helps us guide what we're going to do about it. All of the while looking at the patient and what the patient's requests are and what the patient aims are. Some patients are fit and healthy. These patients are both in their 80s, one runs marathons and one doesn't get off his chair. We might have a very different management strategy for both these two patients, so that is crucial. So the anatomic staging system recommended by the World Vascular Guidelines Group is GLASS. So this is the global limb anatomic staging system. If you look at the top right diagram, it tells us what we tend to expect in terms of pattern of arterial disease. So distal disease, crural vessel disease is typical in age, diabetics, and also renal failure. And patients that are smokers and hypertension tend to have more proximal inflow disease. This GLASS classification tells us how short or long the occlusions are and what the estimations of technical failure and year limb-based patencies are. Obviously, the more severe the disease, the more likely you are to have a technical failure and the reduction in limb-based patency. So this table is a really nice cross-tabulation with regards to the Wi-Fi score and the anatomic complexity of the disease. The more complex the disease, the more likely you are to provide an open strategy, because more complex disease often requires open surgery. And this cross-tabulation is really helpful in focusing our efforts on whether we're looking at an open or an endovascular approach. So this GLASS classification assumes an adequate inflow disease, and the task classification here tells us whether an open or endovascular approach is appropriate for inflow disease, so in the autoiliac and the femoral segment. Task A and B tend to be short segment stenoses or occlusions best managed endovascularly. Type C and D are aortoiliac occlusions and much more extensive disease, usually best managed open, obviously depending on a patient's comorbidities. New endovascular techniques, for example, CRAB, are looking at revascularizing much more significant aortoiliac segment disease. And we look forward to the evolution of that in the next few years for those more high-risk patients. So obviously, I'm from the UK, so I'm going to mention the BASIL trial, of course, the level 1 evidence looking at angioplasty versus open surgery. This cartoon character is Basil Brush, just to add in a bit of British culture to hopefully help you remember the BASIL trial, this happy chap. So UK multi-center randomized controlled trial, 27 hospitals looking at open surgery versus bypass for critical limb ischemia. And in summary, this said that there were broadly similar outcomes in terms of amputation-free survival in surgery versus endovascular. However, with endovascular intervention, there is a slightly higher intervention rate with the obvious morbidities associated with that. The summary on interpretation of this paper is if you've got a patient who's going to last greater than 5 years, who has a long longevity, an open bypass situation is better, and endovascular if the patient has a shorter life expectancy as a broad brush. But it's obviously much more complex than that in real life, and patient-centered decision-making is very important. BASIL 2 is regarding infrapopliteal disease. We look forward to the results of that. And BASIL 3 is going to look at bare metal versus bare metal and plain balloon angioplasty versus drug-coated balloons and drug-eluting stents, looking at amputation-free survival and a cost-effective analysis. So we look forward to the results of that. Obviously, in order to employ an open strategy, you need a conduit. So open autologous vein is preferred, and you can also use arm vein, as we know, and prosthetic. If you're going to use a prosthetic, a vein cuff may be appropriate, particularly distally. There's no evidence support either reversed or in situ vein grafting, and that is surgeon preference. This paper from the 80s, the Frank Beef paper, is still very relevant, looking at using prosthetic versus vein in an above knee bypass, equivalent pretty much in patency, whereas below knee we're looking at vein being most appropriate, or at least prosthetic with a vein cuff. An amputation is still a therapeutic intervention that can get a patient out of pain and trouble, and isn't necessarily a disaster for the patient and may well bring them some relief and some improved quality of life. Best medical therapy is always paramount. We know that many of our patients suffer with heart attacks and strokes, and this is a huge opportunity for us to really save lives in our patient group. Evaluating the cardiovascular risk, looking at statins, obviously high-dose statins, an antiplatelet agent. Clopidogrel tends to be better as per the Capri trial in terms of revascularization, and the low-dose rivaroxaban plus aspirin in the Compass trial, looking at major cardiovascular events, has proved efficacious. Managing hypertension, smoking, and diabetes. It might seem very basic, but doing all these very basic things very well is going to have a huge output for our patients, and important not to focus on the high-tech things and look at doing these very basic things well. Very important for us to stay positive. We often have a long relationship with these patients. If we engage them and stay positive with them, hopefully they can comply with our interventions. And don't forget Basil Brush and the BASIL trial. Thank you very much, and I'm looking forward to a discussion and further debate and your questions.
And it's us thanking you, Claire. Outstanding job indeed. And now we start with the first mentor, Professor Chi. Willie, you are with us, so would you like to go live?
Yeah, let me go ahead and just share my slides real quick here. I'll go ahead and start. Can everybody see my slides?
Yes.
Okay, well, thank you, Claire, for such a wonderful presentation. I think that you certainly do great. I do not have any disclosure related to my comments. So we all heard from Dr. Webster about the nature of CLTI, which is a recent name change. Claire did a wonderful job in terms of discussing the Fontaine and the Rutherford classification, in addition to the Wi-Fi classification, which is something that is more recent. Now, Claire did go over very specific and many practical standpoints in terms of how we clinical manage these patients, especially using the task classification as a determinant to whether patients should receive open surgery, bypass versus endovascular means. She went over the Basel 1 trial with the conclusion, as well as awaiting the result of Basel 2 and 3. And certainly, last but not least, very pertinent practical clinical applications, including amputation goals. So there's very little I would add to Claire's talk. But I will just mention that a study that was done by the Dartmouth group looking at re-intervention amputation-free survival, as well as MAIL, which is major adverse limb outcome-free survival, looking at the graph that for patients underwent re-intervention, that for both re-intervention free survival and male free survival are all lower. So that's actually a very pertinent fact. Now, more than so, what we also know that for both critical limb ischemia as well as collocation, that re-intervention has become an epidemic, meaning restenosis has become an epidemic in PAD, and certainly that there has to be some ramification to this upward trend to help to save patients' life and the very specific limb. Now, in terms of what Claire have discussed, what we try to prevent from, as well as from the standpoint of major adverse limb outcome, is the prevention of ALI or acute limb ischemia, as well as urgent revascularization, looking at both TIMI 50 and TIMI 54, which is the TRA2P study and the PAGAS study. The Pegasus study looking at two different types of anti-platelet agent, which is the first is the Vorapaxar, which is a PAR1 inhibitor, looking at both hospitalization for acute limb ischemia as well as peripheral revascularization. You can see that the patient randomized for Vorapaxar through the TIMI 50 study, that for acute limb ischemia hospitalization and peripheral revascularization are both lower, and the same outcome could be applied to ticagrelor, which is a P2Y12 inhibitor, again denoting the importance of anti-platelet agent or different type of anti-platelet agent. Now, Claire did mention about the COMPASS trial, which is most recently published, looking at rivaroxaban 2.5 milligram BID dosing plus aspirin on a daily basis. As compared with aspirin, you can see that both for MACE and MEL reduction, that the benefit goes towards to those randomized to rivaroxaban and aspirin. But furthermore, the follow-up Voyager trial looking at rivaroxaban versus placebo. Now, this is a smaller trial compared to COMPASS. COMPASS was a 27K patient trial. This is a close to Voyager is about a 7,000 patient trial, but still the outcome is the same. So for that, I would say that besides endovascular and surgical means, we certainly need to maximize the potential of medical therapy in these patients. And thank you for your attention.
Thank you so much, Willie, and thank you for stop sharing. Let me now go back to the academic base of our resident today. So Professor Davis from Imperial College. Prof, would you like to share your slides or record it?
I'll try and share the slides, but if I have any difficulty, we'll...
We are ready. We are ready with the recorded version in case. Perfect. Okay, we see it.
Okay.
Yes, Prof.
Thank you all very much for listening to Claire and to Willie. It was great to hear two experts talking about their interpretation of peripheral arterial disease. I think the key thing really to emphasize to everybody, this is an increasing problem that we are going to be confronted with. It is actually, whether we like it or not, poorly managed. There's a lot of medical education that needs to happen. And we also need to look at making sure that people actually get their best medical therapy to actually prevent them losing their legs. Now, this may be a predominantly venous audience, and I think it's very important, and this is looking at some UK data, to really just re-emphasize that it's much more common for us to be intervening on venous disease than it is actually to be offering interventions for critical limb ischemia, abdominal aortic aneurysms, or CEA. So it's very important to get this all into some degree of perspective. Now, this is some work that I did a long time ago, and I wasn't going to put the slide up, but I thought it would be interesting just to show you something that I devised when I was a resident. And you're all very much familiar with what is the symptoms of acute ischemia, and known as the 6 Ps. Then there are those things that we've all heard about to do with chronic disease, claudication, rest pain, ulceration, and necrosis. But often it's difficult to work out what will be irreversible. And I would like to suggest that you should use the 4 Ms: mottling, muscle tenderness, motor and sensory loss, and major necrosis. They're all things that may suggest irreversibility and that actually limb loss is inevitable. Now, I can't really overemphasize enough the importance of medical therapy, but it's very interesting to note that if you look at the bottom right-hand caption, you can see that if you take a 65-year-old claudicant, they have a 2-fold increased risk of cardiovascular or cerebrovascular disease. And if you can get them to stop smoking, exercise, statins, and antiplatelets, and they all give you relative reductions. And there is some evidence to suggest that if you can optimize their medical therapy, after 2 years, you more or less can get back to a normal risk of people who have never smoked. One thing we haven't talked on about very much is actually the importance of getting people to exercise. This obviously has 2 benefits. One, it has a benefit with respect to cardiovascular disease and maybe even patients' perception of life, but can actually significantly improve people's symptoms of claudication. What is also very important that NICE made some recommendations in 2012 and updated them in 2020, and there are a number of research recommendations. The first 3 are all to do with looking at tools for diagnosing the accuracy of arterial disease in patients with diabetes, such that there's a study that's just been published in the Annals of Surgery called the TREAD study, which has highlighted a new way of looking at waveforms to actually improve the diagnostic accuracy of Doppler with respect to diagnosing arterial disease. There's a recently funded study in the United Kingdom called the DM-PAD study, which has been funded by the NIHR, that will report in 2 or 3 years' time, and is just looking at 7 different ways in which you can diagnose or confirm the diagnosis of peripheral arterial disease, and I think will actually be a landmark study in this very difficult area. We've already heard about the Basel studies, and this was highlighting the need for the Basel II study. And again, I think this will be important. But I think it's very important when you're looking at the Basel I and Basel II studies, even though the clinical evidence with Basel I is very much in favor of open surgery if you've got a survival benefit of at least 2 years. But there is a degree of pragmatism that occurs in real clinical practice as to the time taken to do a long distal bypass compared to maybe less time to do an angioplasty. Another question that they raised, and if you were to go around the audience, everybody would say to you that supervised exercise programs are of benefit. But the answer is, if you look at the US, and certainly in the UK, only about 32% of secondary care centers will actually offer a proper supervised exercise program. And my information in the States, it has only in the last year been a recognized treatment that will be reimbursed by the insurers. And one thing we often do forget, but Claire touched on it very briefly, is the importance of patients' attitudes and beliefs about peripheral arterial disease, because these are really a key of getting people to conform with best management and what actually are people's fears. how much are people worried about losing their leg? Now, there's some work that's being done looking at whether you should just use primary or secondary stenting in the infrageniculate vessels, and the jury is probably still out. Those people who are very endovascular enthusiasts would probably say that, yes, you should go for primary stenting. And then there's the discussion about chemical sympathectomy. This was another recommendation for an RCT or for further work to be done. But I think what's very important, the old adage to remember that when we were thinking of patients having chemical sympathectomies, that we would consider that the blood was being taken away from the muscle to the skin and may potentially make things worse. So, ladies and gentlemen, I've left you with the 8 questions that NICE have posed. You've heard a fantastic lecture from Claire, who's put everything together with respect to the clinical picture, and I very much look forward to the debate. Thank you very much.
Thank you so much, Prof. And now we start with the World Scientific round, starting with a dear friend and great expert, Professor González Ochoa from Mexico. Alejandro, the mic is yours.
Thank you. And thank you for the invitation. Congratulations to Dr. Webster. It feels weird talking about arterial disease in this webinar, but I welcome the opportunity. My question is to Dr. Davis. Particularly the last point of your slide regarding chemical sympathectomy. When I was a resident, I did my share of open lumbar sympathectomies for these patients, and like Professor Laurie said, some of my teachers actually did adventitial denervation when they did open bypass. But what is the current status for sympathectomy? It's more for just pain control. It's not focused on limb salvage in this patient. The use, since we have shift for more diabetic patients in the last decades when regarding to smoking, when sympathectomy was first introduced. So I don't know, what is your take on this, on the current status of sympathectomy?
Well, I think the current status on sympathectomy is that we tend to use it in people who have non-reconstructible arterial disease and have significant skin lesions. I think we tend not that you are having an issue with respect to healing. Certainly our practice would be to use intravenous prostacyclin first to see if a patient got a benefit rather than going straight to a chemical sympathectomy. I'm a bit like you, maybe slightly old in the tooth. I too used to do open lumbar sympathectomies for people who had non-reconstructible disease. And I think the main time we now do open sympathectomies is for those people with hyperhidrosis of the feet, not for critical limb ischemia. But I think there are a small cohort of patients who you might increase their time from eventually going on to have an amputation. But I think it's a technique that we should use, but probably not in the primary treatment, but really reserved for those people who are non-reconstructible.
Thank you so much, Alun. And now we fly all the way to Uruguay. I wish it was me introducing him because he's a dear friend, but it will be Professor Bottini.
It's my pleasure to introduce a very close friend, Latin American leader and president of the Uruguayan Society of Phlebology and Nephrology, Dr. Alfredo Prego. Alfredo, whenever you are
ready. Good morning, everyone. Thank you, Sergio and Oscar, for allowing me to be a part of the great project. And I want to congratulate to Claire for an excellent presentation. First, I agree with Dr. Webster that the treatment of patients with critical treatment limb ischemia should be realistic and pragmatic, because these patients have an increased mortality rate, 50% at 5 years, and high risk of major amputation during this year. Critical limb ischemia must be considered a systematic or systemic disease and that need a multidisciplinary approach would include best medical treatment without any doubt. I also agree with the endovascular treatment in our service is the first option for the revascularization based on Basel 2 and 3 and best CLA trials, because the Basel 1 is included infrapopliteal and suprapopliteal revascularization. And finally, in my comment, our group support also the use of low dose of rivaroxaban plus aspirin to improve the patency of the procedure. And my question to Dr. Wester is if in her hospital, in the Imperial College, the approach is similar than we have in South America, or is different in any way? Thank you very much.
Thank you. No, it sounds like based on what you've just said, we have a very similar approach to the patients, a sensible and pragmatic viewpoint, determining what the patient actually wants and what their aims are. For many patients, ambulation isn't actually a priority, and they might opt for an amputation rather than complex revascularization with a high anesthetic risk and much time in hospital. Also agree we're employing the COMPASS trial a lot more now in our basic practice. It's interesting that COMPASS didn't compare clopidogrel and didn't have that as a part. So I think that would be a next step forward to compare, because we know from the Capri trial that clopidogrel can be better and more efficacious than aspirin in isolation. It would be interesting to compare rivaroxaban and aspirin with clopidogrel to see which one is best. But no, it sounds like we've got a very a similar way at looking at things, and it's so not, Basil, was so nice to know that we've got both options for open or endovascular with equivalent outcomes, so that we can make a patient-centered approach depending on what's the most appropriate for them and their anesthetic risk and their wishes as well. So no, thank you very much for the comments.
Thank you, great job.
Thank you so much to Professor Prego and Claire. And now we fly all the way to Germany. Once again, I wish it was me introducing him as a very good friend, but it will be Professor Che.
Next, we have Dr. Shengao, who is a world-renowned expert in edema management from Germany. Dr. Shengao.
Thank you so much for inviting me to give some comments. So at first, I'd like to thank you for the excellent presentation. On the first slide, you wrote about what all phlebologists have to know, not only phlebologists, but neurologists and cardiologists, because everybody's only looking for his own area. So when patients have coronary insufficiency, so they, believe me, they have a peripheral arterial disease too. This is clear, but another point is diabetes, as you already mentioned, diabetes 2 to 4 fold higher PAD than normal, and we have about 12 to 20% of the arterial disease patients with diabetes mellitus. Just one question, and early my beginning, so in early 80s, we started in critical ischemia with arvine. Arvine was a poison from a South American snail, and it reduced fibrinogen. And we had pretty good results. We took it about 6 to 8 weeks. After that, the patient developed antibodies. And so then we started with aspirin. And now I think the combination to reduce fibrinogen and the combination after that with rivaroxaban and ASS would be a good idea. What do you think about that?
I think that's extremely interesting. We know obviously the increased fibrinogen in both major cardiovascular events and major limb events is elevated. So controlling fibrinogen levels makes perfect sense. We know that things like stopping smoking and also reducing weight and also actually a little bit of alcohol apparently all reduce fibrinogen. And interestingly enough, there's been quite a few papers looking at the role of statin in reducing fibrinogen. And a couple of studies did actually show that statins did reduce fibrinogen, but a couple of sort of refuted that. So I think the jury's out on that. But I think certainly, obviously, fibrinogen increases your blood viscosity. I think that the antiplatelet agents are important. Our NICE guidelines, which we use in the UK, actually don't recommend, so for example, using fibrates to reduce fibrinogen. They don't recommend them in first line, and it took me a while to tease out why that is. They recommend them if a patient doesn't tolerate atorvastatin or a simple statin, simvastatin. So it can be recommended in someone who doesn't tolerate statins or someone who has very complex familial hypercholesterolemia, which we're struggling to control. And the reason for that is because of the risk of rhabdomyolysis, apparently with the fibrates. But it's a really interesting question. I'd be interested to see where that snake, if they use that anywhere else in the world, but that really is fascinating. And I wonder if that can be obtained anywhere on the black market. It'd be an interesting trial.
Thank you so much, Claire. And now we move all the way to China. It will be my pleasure to introduce Professor Jin Song. I had some slides ready, but I see her here. So we were expecting some technical difficulties also because it's very late in China. But thank you so much for being here, Jin Song. And I see you are with us live. So would you like to speak live?
Oh, sure.
Lovely.
It's very, I'm very happy to meet. So you want me to share the screen?
Yeah, please.
Okay.
That's good.
Right. And so dear Chairman, colleagues, and the audience, I'm very happy to meet you in this webinar meeting and and the first speaker talk about the guideline on the critical limb ischemia, and we translated it into Chinese, and it will be published very soon in our journal. And the great research will lead us together to discuss the topic of chronic venous disease with PAD patients measurement, and we see these ulcers, and we see we see the patients with both vein and arterial disease. In clinics, we see some patients with ulcer in the limb, which might be caused by venous problem or by arterial disease. The ulcer location differs between PAD and chronic venous disease, also caused by vein problem usually locates by the PAD usually located in the distal toes or calf with necrotic tissue, while also caused by venous disease usually occurs around the ankle with wet infection. A few patients with both problems. Patients complain pain, cold, and swollen. In this condition, and PAD problem should be managed priority with bypass and vascular management, followed by venous problems management. And we all know, like with patients, when ABI is less than 0.6, it's not recommended to wear elastic stocking. And we should particularly alert with chronic venous disease with peripheral arterial disease measurements, especially in the old patients. And next, I would like to ask two questions with the speakers. One is, how do you deal with the blue toes when you do the endo intervention? And the second one, like we know, like the basal study and some studies shows the long term of bypass is better than the endovascular. But in the real world, endo, I mean, there are more endo interventions in the hospitals than the bypass. And how do you evaluate? I mean, shall we do some clinical studies to find out what's the true in the real world for the patients with PAD? I mean, bypass or endo. Thank you.
Thank you so much, Jin Song. Willie, would you like to take the comment?
Yeah, sure. Thank you, Jin Song, for such a wonderful comment. So I'm just going to focus on the compression issues with patient with PAD or even mixed ulcer. I think that certainly, like Fedor and I, as well as Dr. Mansella, have discussed about the utility of compression in patients with PAD, especially with the ABI that's low. One thing I want to precaution everybody is that the different type of compression therapy we have, whether it will be elastic, inelastic, or even compression pump, have different physiologic effect. And the physiologic effect is not only the compression product itself, but what it causes in terms of what's underlying either muscle or perfusion to the limb. Now, in terms of ABI, just like what Jin Song have said, we still don't know a lot about what would be a good compression, especially in the gray zone, 0.6 to 0.8, because we know from the publication 2019 from the International Wound Journal, suggesting that that is a gray zone that we're not sure about. But keep in mind that for patients with critical limb ischemia, they would benefit from compression pump therapy using high pressure, low period, or pulse type of compression, because that actually will serve to improve nitric oxide release as well as other physiologic phenomena. Now, Fedor did mention about the utility of not using the absolute index, but looking at something such as arterial perfusion pressure, which is, I think, is going to be, if we have a way of accurately measure that, I think that that's going to be more efficacious in terms of measuring those patients. So I think the jury is still out in terms of what would be an adequate device for patients with ABI that are lower, whether it be 0.6, 0.5, because we certainly know that for our elderly patients, they do have oftentimes a combination of both arterial and venous causes to their ulcers. So it's not a simple question.
Thank you, Willie. Prof. or Claire, would you like to go on the blue toe comment?
Yeah, I can take that one on, and Prof might want to intervene after. So blue toes during an endovascular peripheral intervention. So depending on the completion angiography, obviously if there's distal trash and it's microemboli, you've got a couple of options in that you can perform catheter-directed thrombolysis if a patient's got a limb that potentially threatens, so power and sensation are gone. So I think it would be important to examine the patient if they're awake, obviously. So local anesthetic is preferred, I think, in my perspective, for these patients, so you can evaluate them on table, or you can anticoagulate them. And I would potentially, if a patient doesn't have any compromise, admit them overnight for a heparin infusion and potentially anticoagulate them on discharge. If on completion angiography it's a vasospastic event, you can give them some intravenous vasodilators in order to open the distal runoff. And that's very common in younger patients, for example, with more elastic arteries. So that's my comment on that particular question. I don't know if Prof wants to add anything to that.
No, I'm going to think to add to that, other than if Dr. Wang was talking about the sort of classic presentation of the blue toe syndrome, where you have an SFA stenosis, where you've had some embolization, and you end up with a classic blue toe. Then yes, I think all of us would suggest that is the candidate who should be angioplasty rather than surgery. I think the comment I would pass, though, I think while I understand that a lot of people are endovascular enthusiasts, I think if you look at the Basel I trial, it does show very clearly that if you've got good quality vein and you've got a patient who is going to be alive for over 2 years, you have a much better amputation-free survival. I think the reason that people don't want to offer surgery is that it may take people a lot longer. There's a longer hospital stay. But I think if you're looking at it with a nice hat and looking at cost, it is still cost effective in that cohort to actually offer surgery rather than an endovascular intervention that you may need to repeat, and particularly if you're using stenting. My own personal other interest will be the fact that when we look at Basel II, when the results come out, is whether we will all believe with the one adage about just having single vessel flow all the way down to the ankle. I many years ago worked at the Deaconess in Boston at the Joslin Center, and they very much were of the view that the bigger vein pipe you could put down from the infragenicular popliteal onto another vessel, the better. So I think there is some argument to suggest that we may well expect that with a good volume and a good runoff vessel, we may well expect better results from open surgery in the infrageniculate area. But I accept the RCT is ongoing and we wait to see. And I think the other thing that as I was highlighting, and I think does need to be tested, is this argument, is one blood vessel going down to the ankle enough, or should we maximize the number? But maybe that's a trial for somebody younger in the audience to want to go on and do.
Thank you so much, Prof. We are at the end of this second round, so I will repeat the same comment because it's absolutely evidence-based, genetic and environmental factors. So congratulations to Claire for the brilliant talk and to the mentors for grooming that. Now we go toward the conclusion. Another mission of this initiative is the one of giving visibility to the audience and bringing the audience on stage. So we selected an evidence-based comment we received in the previous day, and the selection came on the person of Dr. Mohammed Ramadan from Egypt. And here is his talk, and then we will have him live with us.
Atherosclerosis and venous thromboembolism. First of all, I'm grateful to participate in such elegant international program organized by the UN Foundation. Thank you, Professor Giancini. There is a probably association between VTE and atherosclerosis, although definite conclusion could not be yet drawn. Patients of unprovoked venous thromboembolism should be investigated for possibility of atherosclerotic cardiovascular complication in order to control risk profile. The idea of association between arterial and venous disease is appealing because atherosclerosis is associated with activation of platelet anticoagulation, and the increased fibrin turnover thrombophilia cause arterial and venous events. Moreover, both share common risk factors, and that was shown in many studies as aging, obesity, smoking. Goldhaber and his colleagues studied 112,000 women aged 30 to 55 years and found obesity, cigarette smoking, and hypertension were predictors of pulmonary embolism. Hong and his colleagues found association between diabetes mellitus, hypertension, and unprovoked PE. Also, Hong, in his study, conducted a retrospective study investigating association between venous thromboembolism and the coronary atherosclerotic disease by measuring coronary artery calcification, and reported higher incidence of coronary artery calcium 50% in unprovoked venous thromboembolism group versus only 28% in control groups. Rodriguez and the colleagues, in a systematic review, found that statin use decreased level of inflammatory biomarkers, interleukin-6 and interleukin-8 and C-reactive protein that are high in VTE patients, and they concluded, in their words, there is overwhelming support that statin therapy has the ability to increase the incidence of and recurrence of VTE. Also, Jupiter trial showed that the rate of DVT was significantly decreased in patients treated with statin versus controls. So, which predicts the other? Reich and van der Hagen did prospective studies to investigate the incidence of VTE in subclinical atherosclerotic disease and showed opposite results and reported there is no association between VTE and atherosclerosis, and the explanation of that atherosclerotic disease is seen in active VTE conditions and not the opposite, meaning that atherosclerotic disease is not a predictor of VTE. Picatinny and the colleagues showed higher incidence of arterial cardiovascular events in patients affected by unprovoked PE than provoked BE. Durack study, Schulman and his colleagues published study on the extended 10-year follow-up of patients with VTE. The mortality associated with acute myocardial infarction, stroke in patients with previous VTE was higher than expected in general population. Also, Pova and his colleagues explored retrospective unprovoked VTE patients versus cohort control subjects, investigating the rate of subsequent acute myocardial infarction, ischemic stroke, and the peripheral arterial disease, and found 16 events in the VTE group versus only 6 in the control group. So my conclusion, there is undeniable frequent cardiovascular events following unprovoked VTE to the degree that we can consider VTE is a predictor, implying further investigation and risk profile assessment. Thank you.
And with this, we congratulate Dr. Mohammed Ramadan, and we have as an honorary comment Professor Zaza Salvatore Lazarashvili from Georgia. Zaza?
Good evening, dear friends. As Armando called one of the questions provocative, I would like to rate this report as provocative in good sense of the word. It's very interesting presentation, my congratulations. And my question is, in your opinion, which pathophysiological mechanism of the venous thromboembolism affected by statins? Thank you.
Dr. Ramadan?
Oh, thank you, Professor, for very nice words. Actually, the effect of statins on preventing venous thromboembolism is still unclear. However, the studies that reported recently believe that statins have anti-inflammatory and anti-thrombotic events. The anti-inflammatory potentials comes from the control of the levels of inflammatory biomarkers, namely the interleukin-6, interleukin-8, C-reactive protein, and monocyte chemotactic protein 1. And also they have the antithrombotic potential through affecting the level of tissue plasminogen activator. They increase the tissue plasminogen activator and the thrombomodulin. Also, they increase the nitrous oxide released by the endothelium. Also, they decrease the tissue plasminogen activator protein inhibitor 1, and they decrease also, or they act to decrease the platelet aggregation. So they practically could be considered as blood thinners. Interestingly, they didn't have any reported bleeding complication.
Thank you so much. Thank you so much, Dr. Ramadan. It was a pleasure having you on stage. And now we go toward the conclusion. As per our tradition, we have the final remarks from another huge figure. And it is my pleasure to introduce Professor Strajček Jaroslav Gerardo from the Czech Society of Phlebology, this time as a patient rather than as a physician, because he's having some health issues that were likely well solved. He should be with us live. So Gerardo, mute yourself. Jaroslav, I see you can see us, but maybe you cannot hear us. It's your time. So if you want to unmute yourself, it's your time. Professor Jaroslav, you are mute. You have to unmute yourself. Jaroslav, unmute yourself.
Jaroslav no escucha nada.
Khaled, if you can send him a signal, and meanwhile we will move forward. If not, there he is. Here you are.
That's good.
Your time.
So, actually, as you can see, I'm in a hospital, University Hospital in Prague 5, 2 days after total replacement of my right knee. And I don't think I'm absolutely concentrated to participate or to say anything positive or negative to this wonderful talk. So if you excuse me, I will participate some days after, and I think Giorgio finds for me a time space, but actually, I just want to greet you and say, this is a wonderful webinar, which I'm listening to, but in this time, I'm impossible to concentrate.
Absolutely no problem, Professor Strajček. Just one question for you. Are you wearing stockings in this moment after total heel replacement?
No.
No stockings. So that's for another time debate on edema control in orthopedic patients.
Once more.
Okay, so thank you so much for your final greetings, and now we go toward the conclusion. I'd like a final word from Professor Bottini and Professor Chi. Oscar and Willie. I don't see. You have to unmute yourself, Oscar.
Thank you. Thank you for participating in this educational proposal for young professional called GREAT. And remember, the doors will open again next week. See you then.
Thank you so much, Oscar and Willie, and thank you so much for having served as mentor and for the early wake up of this morning.
Thank you all, my dear friends, and the great, wonderful, insightful speakers. And I will see you next week.
Thank you so much, and I'd like to deeply thank all the stellar faculty today involved in this new project involving residents. It was truly beautiful to see how much we learned from residents rather than teaching them today. Deeply thank once again, of course, to Mehdi for having made possible this approach to the residents and this approach to the arterial and the venous ward together. I was pretty touched by the comment of our friend Professor Gonzalez. He said it's a little bit weird to be here talking about arteries in a phlebology meeting, but I think that it should be weird no more and having more integration between the two aspects that are always vascular, of course. I look forward for welcoming June 19 faculty. I really like this quote that is saying the greatest good you can do for another is not just to share your riches, but to reveal to him, I would say also her, his or her own. So I deeply thank the mentors who have enlightened the residents today. I look forward for seeing you next Saturday. Thank you so much. Have a nice weekend. Bye.
Bye.
Ciao.
Bye.
Bye.